Okay. Welcome, everybody. I apologize for being a little bit late. That is Jason's fault entirely. Actually, it's my fault
Hey,
entirely. If I could throw somebody else under the bus, I always take that opportunity to do so. It is entirely my fault, but we are really fortunate today to have Dr. Anahita Maybody and Melanie Burr from Schulich School of Medicine and Dentistry to talk about genetic testing and next generation genetic testing in people with intellectual disabilities, which is a rapidly evolving field, as we know. And I think to get an update and recommendations is, as a clinician, it's always really valuable to know what the sort of current status is and what the current recommendations are. So I'm personally looking forward to the talk today. So we have two figures I said. So Melanie Burr is from California and chose for some reason to make the trek north. She did her undergraduate degree at the University of California, Santa Cruz, which is the home of the banana slugs, and then is currently doing her master's degree in clinical science at Western in pathological to be a pathology assistant, which will qualify her to work in a lab. And our other speaker is Dr. Anahita Maybody. So Anahita did her undergraduate degree and her master's degree at Azad University in Tehran, and also did her PhD in genetics at Tehran University in Tehran. Following that, she moved to Ottawa, where she did her two fellowships, one in molecular genetics and one in cytogenetics, before moving down the highway to London. She's now the section head of cytogenetics at London Health Sciences Centre and is also an assistant professor in the Department of Pharmacy and Laboratory Medicine. So, welcome, Melanie and Anahita, and thank you for joining us. And I will turn everything over to you guys.
Okay, thank you. Let me just share my screen. Okay, so good afternoon, everyone. Thank you for attending today's developmental disability rounds. As Rob said, my name is Melanie Burr. I am a current student at the pathologist assistant program here at Western University. And I'm here today to present my research project, optimizing genomic testing in patients with epilepsy and intellectual disability, comparing chromosomal microarray and next generation sequencing. So this work was completed under the supervision of Dr. Anahita Mohseni-Maybody and Dr. Lila Schenkel, and with collaboration with the cytogenetics and molecular genetics lab at London Health Sciences Centre. So before beginning, I'd like to acknowledge that the study did receive financial support from the Developmental Disabilities Program in the Department of Psychiatry at the Schulich School of Medicine and Dentistry in the form of the Dr. Benjamin Goldberg Research Award. So I want to thank the department for their support. For today's presentation, I'll provide some background information, including an overview of epilepsy and intellectual disability, and also the link between these two conditions. I will also introduce the two genetic testing modalities we looked at in this study, next-generation sequencing and chromosomal microarray, and I will discuss the capabilities and limitations of variant detection in these methods. Next, I will discuss the methods and results of the study, including the demographic of patients in our cohort, the types of variants detected, and the diagnostic yields of each testing modality. Finally, I'll conclude with a discussion of the clinical implications of our findings and some possible future research directions. Oops. Okay. So epilepsy is a chronic neurological disorder characterized by abnormal electrical activity in the brain. These abnormal signals can cause seizures, which can present in a variety of ways, including involuntary movement, sensory disturbance, behavioral changes, or altered consciousness. Clinically, epilepsy is defined as the occurrence of two or more unprovoked seizures, and the severity and frequency of seizures can vary significantly between individuals, and epilepsy is often associated with a range of additional neurological or developmental conditions, one of these being intellectual disability, which we will focus on in this presentation. So epilepsy represents a significant global health burden. Worldwide, it affects 1 in 100 people, and here in Ontario specifically, almost 90,000 people live with epilepsy. Epilepsy affects individuals of all stages of life, from newborns to individuals over the sixth decade of life. And the causes of epilepsy are diverse and may include infectious, structural, metabolic, immune-mediated, and genetic etiologies. Importantly, for this study, approximately 30% of epilepsy cases are estimated to have a genetic origin. And because of this, genetic testing has become an increasingly important tool in the clinical investigation of epilepsy. Intellectual disability, or shortened to ID, is defined according to the DSM-5 as lifelong deficits in intellectual functioning, such as reasoning, learning, and problem solving. In addition, individuals must demonstrate impairments in adaptive functioning, which can affect everyday activities like communication, social participation, and independent living. And these deficits must also begin during childhood in order to meet diagnostic criteria. So the link between intellectual disability and epilepsy is well established. Approximately 25% of individuals with epilepsy are also diagnosed with intellectual disability. Epilepsy is also seen more frequently in individuals with severe intellectual disability, suggesting a shared neurological or developmental basis. In individuals with intellectual disability, epilepsy is the most common ambulatory care sensitivity condition, which are conditions in which prevention or effective management in primary care should decrease the risk of hospitalization. So for these conditions, ASCs are used as an indicator of access to quality primary care. Additionally, the risk of sudden and unexplained death in epilepsy, or SUDEP, is higher in individuals who have both epilepsy and intellectual disability. So because of these risks, effective diagnosis and management of epilepsy in this population is particularly important. So identifying the genetic cause of epilepsy can have several important clinical benefits. First, epilepsy is a treatable condition, and identification of the underlying etiology can confirm a diagnosis of epilepsy and can begin treatment for patients to effectively control seizures. Additionally, specific genetic findings may guide treatment selection since certain epilepsy syndromes respond better to different medications or treatments. Next, genetic diagnosis can provide valuable information about prognosis and disease progression. And genetic diagnosis reduces the diagnostic odyssey, which refers to the long and often frustrating process many patients undergo before receiving a definitive diagnosis. Finally, identifying a genetic variant can allow for genetic counseling, helping families understand recurrence risk and potential implications for other family members. So epilepsy is a condition that can greatly affect an individual's quality of life, affecting things such as independence, social life, and employment. Proper diagnosis and treatment is essential to provide patients with the support they need to effectively tackle these challenges. So in clinical practice, genetic testing methods can be used to investigate the etiology of unexplained epilepsy. So in this study, we focus on two primary approaches: chromosomal microarray, CMA, and next generation sequencing, or NGS. So both techniques are widely used in clinical genetics, but differ in the types of genetic variants that they detect. So the key clinical question we want to address in this study is, which of these tests should be prioritized in patients who have both epilepsy and intellectual disability? So starting with chromosomal microarray, it is designed to detect copy number variants, also known as CNVs. These are segments of DNA that are either duplicated or deleted, resulting in an abnormal number of copies of a particular genomic region. CMA can also detect absence of heterozygosity or a loss of one of the two copies of an inherited segment of DNA. Absence of heterozygosity can be important if autosomal recessive genes are within these areas. Currently, CMA is recommended as a first-tier test for individuals with developmental disabilities, including intellectual disability, developmental delay, and autism spectrum disorder. Next generation sequencing is the other genetic test we analyzed in this study. So rather than detecting large structural changes, next generation sequencing is designed to identify small scale variants, including single nucleotide variants or SNVs, as well as small insertions and deletions known as indels. NGS can be applied in several ways, including whole genome sequencing, whole exome sequencing, or targeted gene panels. In this study, we look at targeted epilepsy gene panels that are designed to detect mutations in genes known to be associated with epilepsy syndromes. Additionally, NGS has shown some utility in detecting some CNVs. So this is the decision tree recommended by LHSC for for choosing a specific next generation sequencing panel. And so as you can see on this slide, recommendations are based off of things like age of seizure onset, things like if the patient has syndromic or non-syndromic epilepsy, and in some cases, accompanying comorbidities such as, excuse me, global developmental delay and intellectual disability. Additionally, this can be broken up into generalized seizures, as seen on this slide, or focal seizures as well. So because chromosomal microarray and next generation sequencing detect different types of variants, they each have unique strengths and limitations. So next generation sequencing excels at identifying small sequence variants, which often represent pathogenic mutations in epilepsy-associated genes. In contrast, CMA is better suited to detecting large deletions and duplications across the genome. Some limitations for CMA are they cannot detect single nucleotide variants or small insertions and deletions, while NGS may have limited sensitivity for copy number variants. Additionally, chromosomal microarray cannot detect balanced structural rearrangements, meaning that while no genetic material is gained or lost, a gene may not be expressed correctly if the breakpoint of the loss is within an important gene. So these differences raise an important clinical question. Is one test sufficient or are both tests necessary to maximize diagnostic yield? And the primary objective we're looking at is there a significant difference in diagnostic yield between chromosomal microarray and next generation sequencing in patients with epilepsy who also have intellectual disability? Diagnostic yield being the proportion of tests that identify a pathogenic or likely pathogenic variant that explains the patient's condition. So previous papers comparing the diagnostic yields of next-generation sequencing and chromosomal microarray for patients with epilepsy have found next-generation sequencing epilepsy-specific panels to have a higher diagnostic yield when compared to CMA. These diagnostic yields refer to patients with epilepsy, regardless of their accompanying phenotype. So Sanchez, Fernandez, and colleagues did not specifically look into populations of patients with epilepsy and comorbidities, but they do theorize that CMA is the more cost-effective approach in a patient with epilepsy and autism spectrum disorder, intellectual disability, or dysmorphic features. On the contrary, Burke and colleagues found that patients with epilepsy and neurological findings were significantly more likely to obtain a diagnostic result from next-generation sequencing than chromosomal microarray, with diagnostic yields of 20% for epilepsy gene panels and 7.8% for CMA. So the variability in literature highlights the need for additional comparative studies, particularly in patients with epilepsy and intellectual disability. So for this study, we analyzed genetic testing results from 198 patients referred for epilepsy genetic testing at London Health Sciences Center that had undergone both chromosomal microarray and next-generation sequencing. So this resulted in a total of 396 results. The patients ranged in age from newborn to 79 years old. The cohort consists of 48% female and 52% male. And among 198 patients, 101 of the individuals were identified as having intellectual disability. And so you can see here in the overall patient pool, most patients are referred to one form of genetic test over the other instead of both CMA and NGS concurrently. And so we would like to investigate if there's a more efficient way to refer these patients. So the majority of patients in this cohort did have additional neurological or developmental comorbidities. 87% of patients had at least one comorbidity in addition to epilepsy. And so these comorbidities included intellectual disability, developmental delay, autism spectrum disorder, attention deficit hyperactivity disorder, and gross and fine motor delays. Only 25 patients, or 12.6% of our cohort, had epilepsy without any reported comorbidities. This reflects the complex clinical presentation often seen in patients referred for genetic testing. So genetic variants detected by CMA and NGS were classified using the American College of Medical Genetics standards. For CMA, results were categorized as normal, uncertain significance, likely pathogenic, pathogenic, and for NGS, results were categorized as no pathogenic variants detected, likely benign, unknown significance, likely pathogenic, and pathogenic. In this study, likely pathogenic and pathogenic variants were considered diagnostic findings. So looking at the overall entire cohort of 198 patients, the diagnostic yield for next-generation sequencing was 13.13%, while the diagnostic yield for CMA was 8.08%. And so although next-generation sequencing identified more diagnostic variants overall, statistical analysis showed no significant difference in yield between the two methods. When focusing on patients with intellectual disability and epilepsy specifically, the diagnostic yield for NGS was found to be 11.8%, while the diagnostic yield for chromosomal microarray was found to be 9.9%. And so although the diagnostic yield for next-generation sequencing was again found to be higher, no significant association between test type and diagnostic yield was identified. And so this suggests that neither test significantly outperformed the other in this subgroup. Conversely, for epilepsy only, for patients with epilepsy and no accompanying comorbidities, the diagnostic yields were 24% for next-generation sequencing and 4% for chromosomal microarray. So these results were found to be statistically significant, meaning there was a difference in variant detection capabilities of NGS as compared to CMA. So when examining the types of variants detected by next-generation sequencing, the majority were single nucleotide variants, as seen by the blue bar in this table. And so this was true for both the overall cohort as well as the individuals with comorbid intellectual disability and individuals with epilepsy only. Out of the 26 diagnostic next-generation sequencing results, 21 were single nucleotide variants, while the remainder included small deletions and duplications. Pathogenic variants were detected in 20 different genes, with the most frequent findings occurring in SCN1A, KCNA2, KCNQ2, STXBP1. And so these genes are well-known contributors to epilepsy syndromes. NGS also identified variants with a recessive inheritance pattern, which were not included in our calculation of diagnostic yield, and instead indicate carrier status rather than a definitive diagnosis. So approximately 9% of our NGS results identified pathogenic variants within recessive genes. The gene POLG was the most frequently identified recessive gene in this cohort, and all samples were compared to CMA results, and none revealed a corresponding variant detected by CMA. And although these findings are not considered diagnostic for epilepsy in this analysis, they may still have important implications for genetic counseling, especially when considering family risk. Overall, chromosomal microarray detected 16 diagnostic copy number variants. The majority of these variants were deletions, with only 2 duplications identified. The diagnostic variants occurred across a wide range of chromosomal locations, with chromosome 16 being the most frequently affected. Additionally, of the genes indicated in the CNV interval, the highlighted genes are indicated as being detected by NGS as well, indicating some overlap in the diagnostic capabilities of the testing modalities. So expanding on these recurrent copy number variants, there were a number of recurrent copy number variants identified by CMA, specifically hotspots on chromosomes 15, 16, and 17, as shown here, are actually aligned with a few of our identified CNVs, sharing the same breakpoints due to low copy number repeat mediated non-allelic homologous recombination. So misalignment of low copy repeats during NAHR is an important mechanism underlying chromosomal microdeletion disorders. Additionally, chromosomal microarray identified absence of heterozygosity in 7 patients. So regions with greater than 2% absence of heterozygosity is reported in our CMA results, and absence of heterozygosity spanning 2.2 to 11.65% of the genome was identified between these individuals. While these findings are not clinically significant on their own, they do raise suspicion for recessive or imprinted disorders. So for both testing methods, variants of uncertain significance were the most frequently detected variants. Variants of uncertain significance are very common in genomic testing, reflecting the fact that our ability to detect genetic variants has outpaced our ability to interpret them. So over time, as more genomic data becomes available, some of these variants may eventually be reclassified as either benign or pathogenic, which could change diagnostic interpretation. So there were 11 variants detected by both chromosomal microarray and next-generation sequencing, and 4 of these cases were diagnostic for both methods. So in other cases, the variant detected by one test was classified differently by the other test. For example, some variants were considered pathogenic by chromosomal microarray, but of uncertain significance by next-generation sequencing. And so this highlights a lack of redundancy between the 2 methods, as a test of next-generation sequencing alone would not have detected the pathogenic finding. So these 6 cases demonstrate the diagnostic results from both chromosomal microarray and NGS that overlap. In all cases, the variants were detected by both technologies and were consistent with known epilepsy-associated genetic changes. Additionally, all variants identified in these cases were deletions. And interestingly, next-generation sequencing was also able to detect some copy number variants, including variants affecting genes in NDE1 and SNAP29, which have evidence supporting dosage pathogenicity. So this suggests that next-generation sequencing may have additional clinical utility and identifying certain microdeletion or microduplication syndromes, even though traditionally this is the role of CMA. So the most important finding of this study was that there was no statistically significant difference between the diagnostic yields of CMA and NGS in individuals with epilepsy and comorbid intellectual disability. And so this result contrasts some previous reports suggesting that one method may outperform the other. However, the key observation was that each method detected different types of variants. So our question is, why does there seem to be no difference in the diagnostic capabilities between these two tests? So if we go back and look at the tables from before, we see that the majority of variants detected by NGS were single nucleotide variants, whereas CMA does not have the ability to detect any of these variants. Therefore, the variants would not have been detected if chromosomal microarray alone was used. Similarly, several copy number variants detected by CMA would not have been reliably identified using standard NGS analysis. So, chromosomal microarray became the first-tier test for developmental disorders after studies demonstrated that it outperformed traditional karyotyping. However, more recent studies suggest that epilepsy gene sequencing may outperform chromosomal microarray in identifying genetic causes of epilepsy, although the clinical utility of these results require further research. And so this evolving landscape highlights the need to continually reassess testing strategies as new technologies improve. So based on the findings of this study, chromosomal microarray and next-generation sequencing appear to be highly complementary rather than redundant in patients with epilepsy and comorbid intellectual disability. So each method identifies a distinct class of pathogenic variant, and there was relatively little overlap between the diagnostic findings. So because of this, using both tests together may maximize diagnostic yield and reduce the risk of misdiagnosis. So in conclusion, the study found that there was no statistically significant difference in diagnostic yield between CMA and NGS for patients with epilepsy and intellectual disability. The diagnostic yields observed were consistent with previously published ranges, and each method detected a unique class of variant with limited overlap, suggesting that the relationship between epilepsy, intellectual disability, and copy number variants detected by CMA may be more complex than previously thought. From a clinical perspective, these findings suggest that concurrent testing with both CMA and NGS may be beneficial in patients with epilepsy and intellectual disability, and using both approaches may increase the likelihood of identifying clinically actionable genetic variants. So future research could expand on this study in several ways. First, a larger cohort focusing specifically on epilepsy with intellectual disability may provide additional statistical power. Second, future studies could investigate how diagnostic yield varies with the severity of intellectual disability and how that might be useful for directing treatment approach. Additionally, research could examine patient outcomes following genetic diagnosis rather than focusing solely on diagnostic yields. For projects pivoting from patients with intellectual disability specifically, it would be interesting to see how the diagnostic yield and detective variants in a larger cohort of patients with epilepsy only, how that would look. Additionally, comparison of next-generation sequencing and chromosomal microarray results between patients with comorbidities and patients with epilepsy only may provide further insight into first-tier testing recommendations for each group. So I'd like to thank my supervisors, Dr. Anaida Mozeni-Maybody and Dr. Lila Schenkel. as well as the cytogenetics and molecular genetics laboratory teams at Victoria Hospital for their support throughout this project. Here are my citations for this presentation. And thank you so much for your time and attention this evening, and I'd be happy to take any questions.
Uh, Thank you, Melanie. That was a really nice summary of sort of your work, but also sort of the state of the art, I suppose, and what is recommended. Before we take any questions, Anahita, did you want to provide a commentary or statement?
Oh, thank you, Rob. Yeah, actually, first of all, I should thank my colleague, Dr. Laila Schenkel, for I think Laila is also in that call. So thank you very much for providing the support from the molecular lab. Because the numbers of the samples that we were looking to was much higher in the molecular lab because they have different panels for epilepsy especially, and the numbers were limited in the cytogenetics labs, and the chromosomal microarray samples were much significantly less than the molecular lab. But when we compared and tried to find the samples that they have both tests, it was almost even less than 10% of the cases from the molecular lab that they have both tests. So as Melanie mentioned here, as a final conclusion, we can say that maybe requesting both tests at the same time is going to have a better diagnostic yield. Although, based on the some actually updated guideline that we realized recently. Some maybe retrospectively, some of the classifications of the variants that we have done and reported as VUS may jump up to likely pathogenic because now there are more evidences for their pathogenicity for the neurodevelopmental disorders. So maybe the diagnostic yield of the microarray is slightly being increased. So because the actually CAP guideline was very recently, we didn't have the chance to go and double check every case that we had reported previously. So, but I know that from 2020 till now, it is more than 45 samples that they have reported by the 16p duplication that we previously reported as VUS, and now we should report them as likely path. I don't know how many of them are actually enrolled in this cohort because not necessarily every sample that we had are going to be considered in 198 samples that we had that they had the both tests. But maybe the numbers are slightly being changed. But on the other hand, what I can say is that having both sets at the same time have a better diagnostic yield and a better approach for the patient's management and patient diagnostic. Thank you. Laila, do you want to add something to my explanation?
Let me see if I can.
Am
Oh,
I on mute?
no, you're fine.
Okay, thank you. Yeah, I couldn't find the button, so I saw that you sent me. Thank you so much for the presentation and for the support on this project. I think I just would like to highlight here. These studies show how important it is to perform chromosome microarray in addition to NGS testing in epilepsy patients, especially the ones that have intellectual disability or developmental delay comorbidities, as we show important, significant added diagnostic yield on those cases. Thinking about the case with only epilepsy without any comorbidity, it might be interesting to do an approach of a sequential testing, meaning doing the NGS first, and then if negative, follow up with a secondary chromosome microarray testing because the NGS has a higher diagnostic yield, but I think this really highlights the importance of doing both tests when there is intellectual disability or developmental delay. The other point that I would like to highlight here is of those cases that receive next generation sequencing testing that we don't have overlap microarray testing performed here. Many of those may have microarray testing performed in another lab, so we don't have that data to include here on our analysis. So I just want to flag this. That doesn't mean that we don't have more cases with microarray as well. It's just that those are just our internal case. Yeah, let me know if you also have any questions on the molecular side. Thank you.
Thank you. And if people have questions, you can put them in the chat, or the Q&A, I suppose. But also, if people want to ask questions live, I suppose, so providing some discussion, that'd be better. Just have to raise your hand. So the first question comes from, and I apologize for butchering your name ahead of time, from Salamanesh Ligas. It just says, great work. Thank you for your comprehensive presentation. It goes hand in hand with the recent recommendations by the American Academy of Pediatrics, I think, and the Provincial Genetics Program to use genome-wide sequencing as a first-tier test with microarrays. Question is, in your study or in other work, have you seen any difference in terms of the yield between mild, moderate, and severe intellectual disability? So I assume that means people with epilepsy who have either mild, moderate, or severe intellectual disability. Is there a difference in terms of yield, in terms of finding things?
So actually, to be honest, no, because the requisition that we received is just mentioned that developmental delay and or intellectual disability. So it was a policy in our lab because the microarray requisition has now the second page, and so many of the physicians, especially the physicians that they are family physicians and they are out of the hospital, they just mention other and they don't mention anything else specifically that what is this other that they are mentioning that. So unfortunately, no, we don't have we actually didn't categorize them based on this, but that's a very good idea that we can at least go and find if there are some evidences that we can categorize them based on that. But for this purpose right now, no, they are just intellectual disability or developmental delay as a global term.
And I don't know if primary care people would always know what the severity level is.
Yeah.
But the question that Rhonda Peterson, who works here at CPRI, had just now is, and I guess, Rhonda, the fact that people in the lab just see a requisition, so because Rhonda's question was how intellectual disability was assessed and diagnosed, I suppose at the lab level, you probably wouldn't have any access to that information.
No, we don't.
Yeah. Because I think other research, and if I'm wrong, please say so, I generally, if we're looking at quote unquote just intellectual disability, that if we have known levels of severity, the findings are greater in people with more severe intellectual disability. Is that correct?
Sorry, can you repeat that?
Yeah, so my understanding, and if it's wrong, I'd like to be corrected, is that the lower you go in intelligence, so the more severe the intellectual disability, the greater the likelihood of ignoring epilepsy for the moment, but just in people with intellectual disabilities alone, let's say, that the likelihood of finding a genetic cause is greater the lower you go in cognitive ability and intelligence. So more severe intellectual disability. Is that accurate?
Yeah. Yeah.
Okay. I think genetic cause also you see more when you have more syndromic phenotype, so other phenotypes in addition to the intellectual disability alone, rather than just the severity of intellectual disability.
Okay. Well, because I've asked other geneticists about that, and because when we say, everybody with an intellectual disability should have genetic testing done, but I suppose some of those people are going to be the bottom of the normal curve. And so if people aren't syndromic and don't have dysmorphic features, what's the likelihood of finding any genetic stuff? Especially with a microarray?
So actually, it's a very approximate question, but generally speaking, we say that microarray can detect between 8 to 12% of the abnormalities in the patients with developmental delay. But now, because the numbers of the probes are going to be increased in the chromosomal microarray platforms, and now we have the SNP microarrays that can also at the same time detect some regions with the UPDs and these kind of stuff. So maybe the diagnostic yields come a little bit higher, but it's never gonna goes more than 15%.
Okay, but I suppose those numbers are evolving then with new technology.
Yes. Yeah,
Uh,
definitely.
and then if I can, there was also a follow-up comment. Oh, sorry. It was congratulations from Salam and Ashligas for me not apparently entirely butchering their name. So I had several questions, but one of them, I guess, to begin with, on a very practical level, when we recommend, or when you say it's recommended to do both microarray and the next generation sequencing, what is the cost of each of those?
So for microarray, I think ministry is gonna reimburse us with $800, but for NGS, I'm not so sure. Laila, do you know?
Yeah, in jazz is about that, about $1,000, and these are funded by the ministry, right? There's no
Yes.
cost to the patient if they meet eligibility. The NGS sequencing is that we are talking here is for epilepsy patients, so they need to have the epilepsy specific phenotype. Of course, intellectual disability is one of the comorbidities, but it's not. Intellectual disability alone is not eligibility for NGS testing, not for this panel specifically.
Okay, but there's not a market difference in costs. There's not that is shouldn't be a reason to pick one over the other.
No, that shouldn't be the reason. It would be
Okay.
more the indication. Yeah.
Yes.
So then there was also a question here from Aaron Marshall. For the absence of heterozygosity cases, did you find a homozygosity AR? I'm not sure what AR is.
Autosomal recessive, yeah.
Okay, AR cause of disease by NGS. And is the sequencing performed on an exome backbone to be able to look at emerging epilepsy genes that might not currently be on your panel?
So for the first part of the question, I can answer that yes, we take a look at those samples, the AS7 samples that we reported the AOH, and in none of them we could find any mutation in the autosomal recessive gene that also encompass that AOH region. But for the second question, maybe Laila is a better person to reply. Laila?
Yeah, if I remember correctly about the new genes being discovered, the epilepsy genetic testing by NGS. We do update the panel content very often, every 1 or 2 years. There is a working group at the provincial level that work on curation of new genes. And so the panel is not too outdated. And this is a really recent, relatively new testing. It's just the last, I guess, 3, 4 years. So we do try to update as new literature comes, but I know it's the new literature is faster than us always, but we try to keep that updated.
So along those lines, what I've wondered for quite a while is two things. One, what does it actually mean for a condition for a gene to be associated with a condition? Is there an official definition? So if somebody once had a mutation in a gene and they also had epilepsy, is that enough to say they're associated, or does there have to be something more? Is one question I have. And then the second one is, who decides what's on the panels?
It's a broad question. We could have a seminar on that.
Yep.
Gene Disease Association, there are working groups that review these publications, both on familial studies, new gene discovery. So there are, for example, CleanGen would be one of the organizations from US that took curation of new gene disease association. That would be one of the resources that we look when creating new panels. That's not the only resource, but it's mostly based on publication and familial studies and functional studies on that gene. What is your second question?
What does it mean for a gene to be associated with a condition? So
You
again, an
Yeah,
example
you
would be,
have clinical and functional evidence, right? Clinical evidence being segregating with the disease in multiple families with the same phenotype. And functional studies showing, for example, they have a mouse model or cellular model and show that defect on that gene result in a specific pathway impairment that is involved on that disease. So yeah, very briefly and basic.
but then my question,
Basic.
but then I would ask about sort of when we talk about having autism panels or intellectual disability panels, which might have thousands of genes, and again, this is not my area of expertise, but I don't, are there thousands of genes that have been associated with either of those conditions where they have sort of segregating in families and studies large enough to say that?
Yeah, there would be evidence for all those genes that there is association of that disease.
Okay, I mean, 'cause I've always wondered that. So, I just, Aaron Marshall, I had one other follow-up question, and I'll come back to you, Ben. But the question, I guess, Lila, was a follow-up. This is from the person who had asked about the new genes and stuff. And so the question was, is it on an exome backbone, though, to be able to do research reanalysis of already sequenced samples?
So the panel right now is, sorry, the NGS is in panel, is not exome backbone.
Okay.
We are transitioning our laboratory to exome or genome backbone. So that will happen in the next 1 to 2 years. So all our NGS germline testing will become exome or genome backbone. But right now it's a panel.
Okay. In the chat, there are a couple of links, both from Anahita and from Lila, for information about testing and epilepsy, and also clinicalgenome.org. All right, so Ben, if you are able to sort that out, let me know because there's nothing I can do at my end now to unmute you. It just says I have to ask you to unmute yourself, which I've done. The I guess one question that I've had philosophically perhaps. So when you say, Melanie, that that genetic testing can provide us with a diagnosis, this may seem like a silly question, but what do you mean by diagnosis?
In terms of diagnosis, is more referring to like an identified variant within a disease-causing gene, like Dr. Schenkel was saying, genes that are known to be associated with epilepsy syndromes. If you can see that there is a variant that is rendering it non-functional, that was what I was referring to.
So is that a diagnosis or is that a cause?
Well, I suppose it would be a cause explaining the patient's phenotype of epilepsy. Um,
Because the reason I ask is, again, it comes up more, I think, in my work with regards to autism and intellectual disability, but I think those are both clinical diagnoses, really. And so testing may help us to understand the cause and someday it may help us with treatment. But people still often, I hear people talking about genetic diagnoses for those things. So is that, and I'm not sure what the official definition of diagnosis is, but what are your thoughts about that?
no, that's a good point to bring up. I agree with you. It does sound like it is a cause explaining like the findings or of a person having seizures and being classified as epilepsy. I also would be curious to now Google, what is the difference between diagnosis and cause?
Yeah, that's a good question. We will race to
So,
that.
Rob, I think it is something that it's a jargon between the geneticists that when they find a variant, either copy number variation or any single nucleotide variation, if they think that it causes the disease and it is completely related with the phenotypes of the disease, they called it as a diagnostic finding. But if this is something that it is there, but they are not so sure if it is going to be related to the phenotype or causing the disease, they don't call it as a diagnostic finding. or this is why we call it a variant of unknown certificate. So in both molecular and cyto, when it is path or likely path, we normally consider them as a diagnostic finding. It is some sort of a jargon between the genetics people.
Because I think that makes sense then when you put it that way, Anahita, because certainly when I've been to presentations about genetic stuff and autism and intellectual disability, and people say, X% did not have a diagnosis, I would say they do have a diagnosis, there's not a genetic diagnosis. I suppose that's what we need to distinguish um, between those things. Because then the next question I would have is, with the findings that you have, Melanie, is there any way to know whether the genes that you found, whether are they epilepsy genes or intellectual disability genes, or are they both intellectual disability and epilepsy genes?
I believe the genes we were looking for originally were for epilepsy, but I'm not sure what proportion is also associated with intellectual disability. So that could be something to look into to see specifically if one method is better at detecting a gene that is indicated in both epilepsy and intellectual disability versus epilepsy only.
Because I think in my experience, it comes up perhaps more in brain imaging studies, where if you have people with comorbidity and you find a difference, but is that due to the combined conditions, or is it due to one or the other, or how does that actually work?
Mm-hmm.
I'm not sure. All right. There's another question here. Okay. So Dr. Goldberg wrote his question. Um, uh, so, uh, Ben, I can't read one thing because he wrote here a quick review of genetics and epilepsy. I assume you did just now. Showed about 10 to 12, and I don't know what the next word is, but had genes for epilepsy. Uh, And I think then the question you have is for every gene that is, well, I guess the question is, so when we talk about treatment, certainly we could talk about pharmacological treatment, but is there anybody looking at gene treatment for epilepsy?
Not that I'm aware of specifically. Um, I'm not familiar with the treatments going forward for epilepsy.
Because when you said earlier that what genetic testing can do is hopefully provide us with a more precise treatment or more,
Mm-hmm.
but given the state of our knowledge of how the human brain actually works,
Right.
any idea what percentage of people have their treatment today determined by genetics?
I'm not sure. No, we don't have like outcome result for this study. We didn't have like the outcome of if there was a difference in treatment management or medication or anything like that.
But I think that would
I,
probably require much better communication, and not at your level, but I think there would have to be
Mhm.
a sort of plan then to have sort of different groups communicating so we can understand that better.
yeah, I agree. Hmm.
I mean, Anahita, in your experience,
So
how,
to be honest, no, we just report the cases and we don't have that much of communications with the physician to see any feedback about the patients. But maybe the treatments that we are talking here are more supportive treatments rather than just cure, because some of them are especially for those patients that they are suffering from the newborns, that they are suffering from the seizures, maybe the damage to the brain cells are not something that can be reversible. So, and it is not something just like phenylketonuria that you say, okay, I know that it is this abnormality, so I try to prevent the patient from eating foods with phenylalanine. So it is not a straightforward A to B or black and white. So um, to be honest, no, I don't have any clue about the treatments that are going to be related to the genetics, but maybe just the whole disease, the treatment is going to be important.
well, and I think I remember Ann Bassett in Toronto talking with 20q deletion, that sometimes a diagnosis can be treatment in a way. Because I think for families, I think as human beings, we always ask the question why. We want to believe the universe is orderly and makes sense. And I think being able to say to a parent, your child has epilepsy and intellectual disability because their brain has developed differently from other people, which I assume is correct, but it also doesn't really mean anything. Whereas I think for families being able to say, look, my child has this problem because of this gene being abnormal, or there being a mutation. I think that can make a huge difference to families, and people then stop asking what they did wrong, and stop
Mhm.
and take that sort of worry away from themselves, which I think can make a huge difference to some families.
So if it is by the genetic etiology and there is no targeted therapy for that, unfortunately, I cannot make a comment that it can be beneficial for them, but maybe just as I mentioned, as a support.
Yeah, that's what I mean too. Yeah, I think that can make a huge difference for people because it answers the question
Hmm.
why that we all want to answer about things.
Yes. Yeah.
All right. Are there other questions for Anahita or Layla or Melanie about genetics and intellectual disability and epilepsy, which, as we've heard, is a huge comorbidity? Okay, well, thank you to the three of you for joining us, Layla, also for stepping in unexpectedly, I suppose. But Anahita, thank you very much, and Melanie as well.
Thank you.
It was a really great update for all of us, I think, and provides a sort of guidance and understanding of where the field is heading. I thought it was excellent. Just along those lines, if people can fill out their evaluations, please, that is in the chat. Jason, is that correct? The link for the evaluations?
Yes, it is, and I'll email it to them with their certificate soon.
Okay, yeah, and that way we can get everybody their continuing professional development um, credits. Just a note about upcoming things. So actually, perhaps in a great example of unintended synchronicity, next month, Dr. Anna Suleimarti, who's a neurologist at University Hospital who is specialized in epilepsy and does a lot of stuff with people with intellectual disabilities, is going to be talking about epilepsy and intellectual disabilities. So it dovetails nicely with the talk today. So that'll be April 8th at 4 p.m. And then if people haven't registered and they're interested, on April 16th at the Ivy Institute on Windermere, we're having our annual continuing professional development afternoon in intellectual disabilities. There's lunches provided, and we'll have three speakers. And information about that can be found on our website, which is at ddp.uwo.ca. And I again want to thank Anahita and Melanie and just I don't know if this is my place to say Anahita, but I will anyway, that Anahita has relatives in Iran and her father recently left Tehran, thankfully for a different part. But I think it'd be nice if we could all keep him and her family in our thoughts because it's not, well, it's pretty terrible what's happening there right now. So we all thinking about you, Anahita, and your family.
Thank you so much, Rob. It
Yeah.
really means a lot to us. Thank you for the kind words. Thank you. And I'm so lucky that I am in a very kind, supportive environment, such as here, that I feel that I'm not emotionally alone. And I do have lots of supports from you guys. God bless all of you. Thank you.
Well, and certainly we hope your father is well also.
Thank you so much. Thank you
All
very
right.
much.
All right. Thank you everybody for joining us, and we'll see you next month. Take care.
Thank
Thank
you. Bye.
you.
Yep. Bye.